So today, so before we start, let me kind of recap who am I. I'm an economist, and so you may be wondering why I'm here talking about homelessness and mental health. My research interest is on social policies to assist very vulnerable population. So, for example, I start with analyzing long-term unemployment and mental illness, and then I get an opportunity to study homelessness, and after studying all this, and I realized a lot of this population, this vulnerable population, they all have a large proportion have adverse childhood experience. So I gradually start to analyze, do research on programs to assist extremely vulnerable children. So early intervention is very important. So my research have two main streams. One is understanding pathway in and out of homelessness and long-term unemployment. Another stream is evaluation of social policy programs to assist those vulnerable population. And as the host mentioned, I do run randomized control trials, but also do quasi-experimental evaluation using administrative data. For example, my research, one of my projects is evaluating the social housing program, a big social housing program introduced by New South Wales state government recently. And I also do analysis on affordable housing, and also the participation in early years education for the most vulnerable children. So let's start about mental health and homelessness. There are quite a few comprehensive review on mental health and homelessness recently. So for example, Origin Youth have a policy paper, A Welcome Home, Youth Homelessness and Mental Health. This report offers comprehensive literature review on relationship with mental health and homelessness, and also the service provision. And also the Productivity Commission report also have a section on mental health and homelessness. And a HURI report also have a very extensive review on this topic. So today's talk, I'm going to focus on the research I've done in the past maybe decades about relationship between mental health and homelessness. And I don't know whether you might have heard about Journey's Home Survey. It's a survey of large scale national survey that follow people experiencing housing instability over time. And so in this research, my research focuses on mental health cause or whether it's a cause or consequences of homelessness. And we also emphasize a little bit about diagnosed mental illness versus undiagnosed mental health issues. And the other research I'm going to talk about is the service for homeless people. And because mental health is have such an important, is the relationship between mental health and homelessness is so strong. So does the service also incorporates the mental health services. So I'm going to present a bit more detail about the evidence from this randomized control trial. And I also draw on some research my colleague did on analysis using Journey's Home data. So first, well, Journey's Home, a little bit about Journey's Home data. It's a longitudinal survey of people who were homeless, at risk of homelessness, or vulnerable to homelessness. It's not a general population household survey. And it's the income support recipient who were flagged by Centrelink staff as homelessness or at risk of homelessness, or they are not flagged, but have high propensity of being homeless or at risk, or at risk. So we define as the top 2% of predicted probability among all Centrelink population. And we follow this population account for approximately 2.9% of all Centrelink income support recipients over the reference period. So you can see this is a population of extremely disadvantaged group. And it's very different from the data that traditionally used to analyze homelessness. So, because many studies, they focus on localized data, data in local area, and their sampling methods using snowballing method. They go to the homeless service provider, the location of homeless service provider, and then they start to collect data from already homeless people. So a lot of information require recording, but while a lot of information rely on qualitative analysis, asking participants their past experience. But while Journey's Home data is a national survey, and it's a stratified random sample from 36 clusters across all states in Australia. And there's 1,682 responded in the first wave. And the survey has very high response rate. And we also follow, the response rate is as good as the general household survey. As we normally know, survey of very vulnerable population normally have very low response rate, but Journey's Home did exceptionally well. And we follow all wave 1 respondents every 6 months for 6 waves. And it has very high re-interview rate. So that means we can pinpoint the entering and exit of vulnerable into homelessness for this vulnerable population. And also the survey content have rich information on individual characteristics and homeless risk factors. And we also have detailed housing information, including housing calendar, track individuals every move, and the precisions by every 10 days. So we know at exact timing when individual entering homelessness, and then so we can study duration of homelessness. And it also allows us to observe survey respondents' homeless entry and exit, and changes in risk factors and other circumstances. So, let's think. So in Journey's Home survey, because we define the researchers can define their definition of homelessness based on the survey questions, because it has very detailed accommodation information. So my study in general follow cultural definition of homelessness. So some study they call it precarious housing. Some people call it housing insecurity. So basically, it's for people, homeless is defined as people without accommodation or staying in accommodation that is below community standard. So below community standard can come from 2 different points. One is is the quality of the accommodation below accommodation standard and the community standard. Another one is security of housing tenure, that's below community standard. And it could also be the cost is way too high, is not affordable by general population. So this includes people sleeping rough on the street, or squatting in an abandoned building, or living in emergency or crisis accommodation, or living in home of friends, or the short-term in home of parents. If long-term, because in home of parents, it's different from the short-term. So we separate out the short-term and long-term. And also we include people in caravan, cabin, mobile homes, boarding or rooming house, hostel, hotel, or motel. So the survey also have mental health measure. Here I only cover the survey has a lot of measures, including like drug, alcohol use, and other, whether a lot of individuals' history, income. But here I only focus on the measure that direct relevant to our today's topic. But if you're interested, I have a it's very rich. The information is very rich. So for mental health measure, we have two different measures. One is ever been diagnosed or has been diagnosed in the last 6 months by a doctor. So and we collect just 5. The only 5 most common, 5 common mental health conditions. Because of the survey length, we cannot collect all the different conditions. And we also collect information on Kessler Psychological Distress Scale, K6. This is kind of act as a screener site. And for Jenny's home, because it's a large sample and it includes the non-homeless population over time, which we can really observe survey respondent homeless entry and exit, and as well as the changes in their risk factors and the other circumstances. And this will allow us to unpack the causal relationship of risk factors and homelessness. As most of the homeless study, what we see is the relationship, and it's very hard to pinpoint the causal relationship. Is a cause or is a consequences without longitudinal data. And that's why Jenny's home is unique. It actually is still unique in the world because the difficulty of reach to this extremely disadvantaged population. And luckily, in Australia, a large proportion of people are on Centrelink payments. So therefore, we can use that as a sampling base to run a survey. So only 6 waves of survey but they also have its caveats, because only 6 waves of survey, they cover about 3 years. And it might be too short to see changes in some factors. For example, drug alcohol addiction, it turned to be much longer than 3 years. And it's hard to, we observe some, just caught people just about to change, but a lot of these changes might be short term. We can't see whether it's a stable change, it's a permanent change, or just temporarily because of treatment that temporarily kind of quit drug and alcohol and then come back on. So the job is, unfortunately, the funding only allow us to collect 3 years data. And the survey was done from 2011 to 2014. So it might it's not very current, but the homeless behavior, homeless people doesn't change that much during this short period of time. So it's still a good data source to understanding the pathway in and out of homelessness and the behavior of homeless population. So, first, let's look at the prevalence of mental health conditions. Of two different measures. One is journeys home, and then for the general population, it's from the National Survey of Mental Health and Well-being. And for homeless people, so you can see the rate is much higher than general population. And no, this is the this measure is the ever diagnosed with bipolar affective disorder or ever diagnosed as schizophrenia. So as you can, and so you can see that it's very high, particularly depression. And if any mental health conditions, it's also higher than general population. So, so this represents this specific, the relationship, there's a strong relationship between mental health and homelessness. So as we might see some people, they might have mental health conditions, but they do not seek, so they do not go to health service providers. So we also do psychological, we also apply, do the survey on the mental health screener. So it's, we use K6, and K6 greater than 13 is considered as probable have mental health conditions. And it's a screener. Of course, the correlation is not 100% with the clinical measure, but it has very strong correlation and it's widely used. And you can see for K6, JH homeless people in Journeys Home Survey, 30.5% has high K6, while general population, I couldn't get information from from the same survey, so I use Hilda survey, wave 7, is about the same time as the National Survey of Mental Health and Wellbeing. So the calculated using Hilda survey for general population is about 15.6%. Have high K10. Oops. I need to go backwards a bit. Previous. Okay, so the K10, it depends. Is about. I can't remember exactly. I think it's the last two category because in Hilda it gives us the high, very high and very high. So there are two categories, and it's broadly comparable with K6 greater than 13. And so it's not 100% comparable, but it's broadly comparable. I'll fill in the exact number there. So the conclusion, there's certainly confirmed there's a strong correlation. So then let's think about, does mental illness or mental ill health cause homelessness? So let's think about what's the cause of normally economists thinking about the cause of homelessness is maintaining stable housing requires certain level of resources. it could be economics, it could be other resources. For example, you need ability to maintain, to pay the bill and maintain housing in reasonable condition. These are all the resources to help people maintain stable housing. People become homelessness maybe because the resources gradually reduce to the level that's insufficient to maintain housing. Or they could experience a shock, a sudden adverse impact that reduce resources below the required level. And this, so for people with very high resources, you need to have an extremely large shock to push them into homelessness. But for vulnerable population that have no resources, a small shock can push people across the line. So that's why we often see vulnerable population, they cycle in and out of homelessness. So the minimum, and there's another contributing factor is the minimum resources required for housing, for maintaining stable housing increased. For example, the rental price go up. This all can also push people into homelessness, because if they have very low resources, they just barely meet the requirement, and then a sudden increase in rental price may cause people entering into homelessness. So, and let's think about how mental ill health can affect homelessness. So for sure, mental ill health lowers people's economic and social resources. For example, they make people disadvantaged in employment or education, or they may increase people's social isolation. And when it gradually reduce people's resources, therefore make them more vulnerable to homelessness. And this is certainly causal, and there are a lot of research related to effect of mental health on income and other, for example, social network. So the question is, do mental ill health precipitate homelessness? If in the Journey Home survey, we ask people, what's the main reason they become homeless? This is the direct answer from respondent. 10%, they say it's because mental health issue. And 36% say it's relationship, family breakdown. And the next two highest one is financial difficulties and being evicted. But if you think about it, mental health issue can cause relationship breakdown. And they can also cause financial difficulties. So really the impact of mental health on homelessness is underestimated if we people's direct answer. So that's why we do a series of research using using panel data research technique that we conditional on all sorts of different conditional on all sorts of different risk factors. So means if you have the same other risk factors, whether mental health precipitate changes in mental health that would affect people's probability of entering or exiting homelessness. And so there's the first part of research is my past research, and then my colleague also did a research using the same data source, but we approach in slightly different way. So So the research we've done is take people who are housed, and we study what affect them become homeless in the next period. And we find if we compare people who ever diagnosed mental health condition with people who never been diagnosed mental health condition, there is no people with mental health condition is not more likely, is actually less likely to entering into homelessness. And you might be wondering why. There are many reasons could explain that. First, it could be people who are diagnosed. That means they are more connected with the services. And it could be people who are more likely to seek services. So they are less likely than other vulnerable population that have never diagnosed mental health condition. But if you look into those who have high psychological distress, but not diagnosed with mental health conditions by a doctor before, and these people are more likely to enter into homelessness after 6 months. But this sample is quite small. But the research does show what we need to think about is people who wasn't diagnosed, didn't access service, mental health service, so they wasn't diagnosed formally. And another possibility for those ever diagnosed condition is the diagnosis of condition can help them to be the priority list for obtaining the housing assistance. Another of my colleagues research using whether the condition, whether changes in mental health condition in the last 6 months affect the changes in housing status. And we can see there's a correlation, there's a causal impact on depression, but not other type of mental health condition. And I'm not surprised with this finding because for others, there are so the depression is more episodic, and for other type of mental health condition tend to last longer. So we might not observe all the changes. So mental health illness a consequence of homelessness? We would think so, because having a home is basic human right. Without one, is certainly detrimental. It's like a food and water is a basic need of an individual, and without a place to go back and relax, it's kind of it certainly have impact on people's mental health. But whether it triggers clinical defined mental illness, it might vary person by person, and it depends on their duration of homelessness and other adverse experience while being homeless. So my colleague had a very interesting study on psychological distress and the duration of homelessness. And they found difference in pattern by gender. For men, the increase in K6 increase after become homeless, but only significant after 1 year. So a short term does not affect their psychological distress level that much. But however, the first 3 months, the homeless here is more like precarious housing, all type of homelessness. But if you only focus on sleeping rough, the first 3 months, the psychological distress increased significantly. But people get used to the sleeping rough, and it reduces, then the psychological distress reduces subsequently. So for women, become homelessness, it increased the average K6 by K6 score by larger, but there is a large variation across individual. So it's not statistically significant. And becoming housed reduce K6 straight away. So for women, seems to be providing secure accommodation at the house, providing them a home is very important to lower their psychological distress. So next, we look at the mental health service usage of homeless people. As we can see, there is no big differences between general homeless people and not homeless people. But if we focus on the most severe form of homelessness, that's sleeping rough or in crisis accommodation, they're less likely to see doctors for mental health issues, and also they're less likely to see mental health professionals compared with other populations. And this is not because the mental health condition is better. And if you look at the K6, they are slightly higher. It's not that large difference, but they're slightly higher. So there is certainly a service access issue there. And if we look at people with a high 6, it's also they have people sleeping rough also have less likely to access services. But there are also some differences by seeing mental health professionals for all homeless compared with non-homeless. But the gap is there, but it's about 10 percentage points. So certainly there's an access issue of homeless population. So there are a lot of key challenges for providing mental health service for homeless population. First is the housing stability issue. People mobile, move around, and then they're very stressed there is no stable housing, which might, if the duration is too long, might further affect people's mental health conditions. Also, there's a complex need because the experience of most of there's high proportion of homeless people that experience child abuse, and they also have drug alcohol issue or family violence issues. So there are complex needs. There also lack of social support from family and friends, especially the long-term homeless people. We define that people who are long-term homeless tend to build a network around other homeless people. It doesn't help to this group of people won't be able to help them get out of the unfavorable state. And another issue is about service accessibility. I will touch a little bit more about that because homeless in my other study. So there's another issue is because of the complex needs, they quite often require long-term services. There is not enough resources to provide these long-term services to this population. And the most most difficult to treat are those who are chronically homeless. They cycle in and out of homelessness, or they have been sleeping rough or in crisis accommodation for a long time. And so this is where my other randomized control study comes in. It's a 3-year intensive support program that based on the concept of housing first, and it's targeted for people with chronic homelessness. And you can see this will put a lot of resources into this treatment because there's very low caseload, one caseworker to 4 clients. And also there's this skill development program, mental health treatment, and drug alcohol. But the drug alcohol, there is no specific intervention. It's taking the harm minimization approach. And we can see, and for the mental health, initially the program negotiated priority access to mental health services in the Alfred Hospital, both inpatient and outpatient services. But it didn't work for the first few, for the initial period, we realized it's not going to work because the participants are not accessing this service because it requires formal appointment, require waiting. And very few people take up this offer. And so therefore, the program changed. It changed to on-site psychologists, to have an on-site psychologist. The psychologists can provide 2 different treatment. One is trauma-informed care. It trains caseworker for trauma-informed care and act as a consultant. And the second one is directed seeing patient, talk to trial participant. So the outcome, because of time, I'm going to jump straight into graph. Because this is very similar to Housing First program, normally is regarded as effective for to solve the homeless issue. But let's look at by Housing First program, only most of them evaluating impact after 2 years. And this study, we follow participants for 6 years. And let's see, and the program is 3 years. Let's see what happened after the program ends. So it do as Housing First, jump up treatment group, the housing maintained. But as soon as program ends, the housing outcomes start to slip back into homelessness. That's because the caseworker is not there to help them solve the housing problem anymore. I also investigated the case note, and you can see a lot of the caseworkers' time is to accompanying this population to solve their housing problem or to the different appointment. So as we can see, the mental health outcome, initially this outcome is high, and then it doesn't change that much, but you can see a small trend start to reduce after 2 years. But at around 30 months time, the program announced the program is going to end because it's a pilot program. It ends 3 years. And the anxiety or stress of the participant start to increase and back to the original level. So as you can see, this ongoing care for this extremely disadvantaged people with chronic homeless issues, the ongoing care is very important. So how do we solve this mental health service for homeless? How do we address this, make the service more effective? We all agree, most of study and analysis agree they require integrated services. Mental health, homeless service, another services that didn't mention much is drug alcohol services. But in my view, this is very important for J2SI participant because there's no specific drug alcohol services. There's 60% have substance abuse problem in the beginning, and at the end, slightly higher. It's around similar, but around the 60% of substance abuse issues. And in maintaining housing for when they have substance abuse issues on their own is very challenging. And also because everybody have different needs, so it needs personalized treatment tailored for individuals' needs. And the system need to be flexible too, because when we have integrated, because for some people, they just need outreach services. And also quite a lot of J2SI participants we see, it takes a long time to build their trust with caseworkers. Some specific cases require up to 4 months' time just to build eye contact. They are extremely disadvantaged population, and these are the population the most difficult to treat. People who experience homelessness for a short time, they are because they haven't experienced that much trauma, so it might be easier to treat. Of course, it depends on their past experience, childhood experience. But for those people who have been in homeless for a long time, it requires time. Another issue is another important issue is responsive, because as I explained, homeless people, they experience shock, and because people with mental health issues, they have very low resources, particularly when they reach homeless, they have very low resources. So any small shock, for example, they have an accident, they might push them into homelessness. So therefore, a responsive, timely ability to overcome shocks to maintain housing is important. And most importantly, needs sufficient resources. Homeless people experience multi-disadvantages. It takes time to overcome their disadvantages.